is the January Department of Board of Public Health meeting. For those of you who are in the right room, if you're in the wrong room, you have a few seconds to leave. Dr. Rodriguez.
Sure. Good afternoon. Go ahead and do roll call. Dr. Curran.
Right here.
Dr. Rodriguez, our president. Dr. Mercer. Dr. Chi.
Present.
Dr. Williams.
Present.
Dr. Shen.
Present.
Dr. White.
Present.
Mr. Harper.
Here.
Major General Carden.
Here.
That's roll call. I also like to present to the committee their minutes from the last meeting. See if there are any questions. If not, ask for a motion for approval.
So moved. All in favor? Dr. Toomey, we'd love to hear from you.
Thank you so much, Dr. Chairman, and also Happy New Year to all of the board members. And thank you. I hope you had a good holiday. You know, 2020 has gotten off to a rapid start. The legislative session has started this week. We have a lot of activity going on. We're anticipating a great deal of health legislation, including some of the issues we've discussed in the past, including maternal mortality. And so we will keep you updated. Megan Andrews will be here today to talk a little bit more detail about some of the things we're anticipating in the session in the days ahead. We also wanted to talk about some of the issues around our Title V block grant, and we'll be hearing that assessment later today, as well as an update on some of our measles activity. Measles, this is turning out to be one of the worst measles seasons we've ever had. And you may be seeing that in your healthcare facilities and practices, and we'll be talking a little bit more about that later in the meeting. Thanks to Dr. Drenzik. I did want to let you know that we have completed our planning grant for HIV, which was due at CDC on December 30th. We turned it in on December 30th. We have not heard back yet about any comments on that grant, but have begun the activities, including the planning activities in Gwinnett, Cobb, and Fulton, as well as continuing in DeKalb County, where we jump-started those activities earlier on. And as part of that work, I had the great privilege of accompanying the members of the Legislative Black Caucus from Georgia to CDC to meet with Dr. Redfield about the activities we're doing around the HIV epidemic. And we had a chance to talk about Metro Atlanta work as well as rural Georgia activities. And as I think you've heard me say before, I've never had the opportunity to meet with the CDC director as a health officer before, let alone take legislators with me to meet with the CDC director. So it was really quite an unusual opportunity for us to hear his vision, but also how we should be working together to end the epidemic in Georgia. But that was followed by another wonderful meeting with the Legislative Black Caucus at the Capitol with the governor. And the governor expressed his support for the work we're doing and the need for us to work together to end the epidemic. And so this was really a red letter day for me to have this kind of leadership at every level of the state and federal government in our HIV work. And I wanted to share that with you because I think that particularly for those of you who have been working in HIV for a long time, this has not always been the case in Georgia. And so I think it really marks a turning point for us to truly be able to address and end the HIV epidemic in Georgia. So I was really pleased that this happened. It was a nice way to close the year and start the new year. And I would like to do something a little bit unconventional. And I would like to turn over my remaining minutes to General Carden. And in his absence, I talked about some of the work he was doing in the Republic of Georgia, both with the Guard, but also that partnership with the Guard has spun off into medical work And it seems to me, as we talked, that there was a tremendous opportunity for public health to play a role in some of that work. And so I will turn over the rest of my minutes to you to complete the Commissioner's report from Georgia.
Well, thank you, Dr. Timmy. I appreciate the opportunity to talk a little bit about what I think the state of Georgia and the Department of Defense doing a lot of good in the country of Georgia. Your Georgia Department of Defense actually has 2 state partnership programs, one with the country of Georgia and the other one with the country of Argentina. We've been partnering with the country of Georgia now for over 25 years, and the one with Argentina is fairly new. And while a lot of it is military to military, there is a whole of government approach, and in that context, actually, health care and access to care was really in Georgia helping through Dr. Ken Walker and Emory before we started working with Georgia, so it even predates the partnership program. And so people ask all the time, why is this important and why do we care? And without giving you a huge geopolitical lesson, all you have to do is look at the map. I was in Tbilisi in early December and saw a sign that said Tehran 1,400 kilometers. So if you look at it from that perspective, with its proximity to Russia and then some other people that we have to deal with, obviously in a very tough neighborhood, and serves as a hedge in many ways against those who would do us harm. So it's very important for us. The country of Georgia per capita is the #1 contributor to Operation Resolute Support in Afghanistan. So they're fighting shoulder to shoulder with men and women across the United States military. In the context of healthcare, we have worked with them, the Department of Defense have, and we have with their Wounded Warrior program, currently treating 230 Georgian service members and 139 Ukrainians in the context of that program. The Department of Defense Medical Security and Cooperation through Foreign Military Financing has spent about $4.2 million in completing a rehab facility, so they continue to work with them. Also, Walter Reed is very involved with respect to research, medical research in the country of Georgia, and with Georgia's has an aspiration to eventually become part of NATO, and that puts 30 other teammates out there with respect to medical research and access to care of those who are obviously in favor of freedom and stability around the world, talking about our NATO partners and allies. And so, anytime we can go out and demonstrate the capacity to do some good outside of just raw military capability, it really sends a great message for our state and our nation, and I think we're doing that. In addition to that, we obviously help train their combat medics. We help them in their rehab facilities, both occupational therapy and physical therapy. With respect to humanitarian assistance, I have a list here from 2012 to 2019 that I won't bore you with, but suffice it to say, you, whether you know it or not, are personally, indirectly involved in doing a whole lot of good for people that need it very, very much. For example, hepatitis C, obviously a huge issue, drug-resistant strains of tuberculosis, just to name a few, are a couple of huge issues that are being worked on there. I mentioned Emory earlier. They are partnered with the United States Agency for International Development. Some of you may have known Dr. Ken Walker, who's now passed, but he's pioneered this work in 1992, 2 weeks before the U.S. ambassador even arrived in the country of Georgia. And he worked with them to establish an emergency medicine program, first for pediatric, then adult emergency rooms in Georgia, a nurses training program, and then a diploma producing nursing program. They went on to create a medical curriculum now for an American medical doctor program, and they're currently admitting 80 students a year. And in 2017, Emory University partnered with the Tbilisi State Medical University and USAID and awarded a $4.2 million grant for an occupational therapy and physical therapy development program. And Emory, again, had a long-standing relationship with Tbilisi State Medical University. And the physical rehab project will result in the building and equipping, manning and training of a new physical rehab hospital in Tbilisi named the Ken Walker University Clinic for Medical Rehabilitation, and they're going to cut the ribbon on that facility this month in Tbilisi. So a huge nexus back to the state of Georgia and what you all are doing every single day. I mentioned a little bit earlier about the Centers for Disease Control. They're working quite a bit in the field of both epidemiology and entomology. With epidemiology, just working basic laboratory security, a huge issue in that part of the world. Early detection for biological threats, surveillance with respect to entomology, and they're working on public labs to support state programs, share lessons learned to not only for their own country, but all of the NATO allies and partners in the region. So without going into a whole lot of detail, it's kind of a 50,000-foot view that I think you all can feel very, very good about not only what Emory and Dr. Ken Walker have done in the past, but what you all are doing now, because what you're doing in your labs and what we learn here, those lessons go back to your teammates that are helping to save lives and alleviate suffering around the globe. So thank you all very much for what you do.
And we are hoping that there'll be some opportunities for the Department of Public Health to play a role in this as his partnerships with the Guard can move forward.
General Cardin, that's a terrific report, and I'm reminded how much it means of the different agencies in the federal government and working with state and local and private people working together to get things done in Georgia. The late Ken Walker was a good friend, and I want to just say one more thing about him. He not only was at Emory, but he was a career-long, decades-long physician at Grady Memorial Hospital, and was the chief medical officer there for many, many years. And in addition, the CDC has started a very unique program in Georgia to work with Gilead Pharmaceuticals to eliminate hepatitis C from the country. They're intending it to be the first, and they have a very lot of hepatitis C in that country. And it's so strategically important because of the oil pipelines and stuff going through. But they're making pretty big progress in showing whether hepatitis C can be eliminated. So it's a lot of different people that have been involved in this. So congratulations to you.
So thank you.
Thanks for helping me out today.
Yes, sir. Yes, ma'am.
Get another virus.
Chairman Curran, Commissioner Toomey, members of the board, it's a great pleasure to be with you again this afternoon and back to talk about influenza. So as a matter of just setting the stage and introduction, influenza is ever-changing, complex, and sometimes difficult to predict. Every season poses its unique challenges, and as such, some of those challenges are very somber reminders that, again, flu will always be a public health significant challenge. So what I'd like to do in the short time that I have with you this afternoon is look at just a snapshot of our current flu season, and we'll look at it both at the national level and also here in Georgia as well. So first of all, the way we can even get to that snapshot is by looking at our influenza surveillance mechanisms. And I just want to remind everyone that the goals of influenza surveillance are not to document every single case of flu. That's not practical, that's not feasible. But the overarching goals of conducting flu surveillance are really the following. We really want to be able to determine where and when flu activity is occurring, when flu season starts, when it peaks, when it ends, what geographic areas are most impacted. We want to be able to have the laboratory capacity to determine what influenza viruses are currently circulating. And very importantly, we want to be able to determine the severity of the flu infections that we're seeing in a given season. Are we seeing a lot of hospitalizations? Are we seeing a lot of deaths? And again, all of these goals really drive our action and inform our control and prevention efforts, whether it's in the very immediate or even for the following season. And so the indicators that we look at to meet those goals are the following. This is the same in Georgia as it is nationally. We have a number of different indicators. We, of course, have the capacity to be able to look at the types of flu viruses that are circulating. That's called virologic surveillance. We look at outpatient illness for influenza-like illness visits. It may not be lab-confirmed flu, but it basically is ILI, or influenza-like illness, fever and cough and sore throat. We look at that both in clinic settings and also in hospital ED settings as well. Here in Georgia, we do surveillance for flu hospitalizations only in the 8-county metro Atlanta area. That's done through our emerging infections program, and those hospitalizations are lab confirmed. And here in Georgia, influenza-associated deaths are notifiable by law in all ages. Nationally, only pediatric flu deaths are reportable, but here in Georgia, we receive information about all flu deaths. And we also kind of look at these indicators to see how widespread flu is across our state and really the intensity level of flu activity. All of these we put together kind of like pieces of the puzzle so that we have a good picture of what's going on flu-wise here in Georgia. So let's take a first look at the snapshot nationally. And it will mirror in some ways our Georgia activity as well. Flu season this year started early. And it actually began here in the southern states. Really the highest intensity of flu activity began in the south. And as of January 4th, nationally, 36 states and jurisdictions actually have high flu activity. But believe it or not, there are still some pockets of geography here in the United States that really have low or even minimal flu activity, particularly in the upper Midwest and in the Midwest, which I think is interesting. When you look at the predominant influenza virus strain that has been circulating nationally, the predominant strain is called influenza B Victoria. That's just the strain name of it. This is a really atypical virus to be circulating in the beginning of a flu season. As a matter of fact, we haven't seen that for greater than 15 years nationally. So influenza B has been the predominant strain up until a week or so ago, but we're starting to really see influenza A, H1N1 increasing now, both nationally and here in Georgia you'll see as well too. When you look at, again, some of those flu indicators that I mentioned, when you look at like kind of the level of ILI outpatient visits, nationally, the level of ILI visits remains high. It's about 5.8% of all visits to healthcare providers out of the total. But when you look at the flu indicators nationally, the indicators of severity, meaning hospitalizations and deaths, are actually not elevated nationally relative to previous seasons. And again, you'll see, I'll give you a preview, it's a little different here in Georgia in that regard. Because the early circulating strains of flu were flu B and now influenza A, H1N1, these strains have a tendency to affect children as far as B goes, and young adults and middle-aged adults as far as H1N1 goes. So because of that, CDC thinks that kind of on balance, because these are kids, perhaps even adolescents and young adults, they may not result in hospitalization and death as likely as kind of when we see H3N2 years. So that might be a difference. And again, it may actually change as the season goes on. But if you look at it nationally, those indicators are not high yet. There have been 32 pediatric flu deaths nationally so far this year. 21 of them have been due to influenza B, and 11 of them have been due to H1N1. And like other seasons, if you look at these pediatric flu deaths nationally, again, only about 20% of them were vaccinated. So let's just look in a little bit more detail, just a little bit about some of those bullet points that I just mentioned. Here's a geographic map of kind of flu activity around the nation. Red is high, and orange is high actually too, But if you see, again, I find it interesting that in some areas of the upper Midwest and in the Midwest, we still are seeing, sort of this low flu activity. Very often, we see geographic differences in flu activity. That's not unusual. What is unusual sometimes if you see kind of simultaneous high activity all across the country at the same time. More typically, like was this year, it starts in one place, such as in the southeast, and spreads around, sometimes slowly, sometimes more rapidly. But we can indeed expect some geographic differences every season. So let's look at the hospitalizations. Remember I said that, again, if you look at it at a national level, the rate of hospitalizations is really not all that much different than in previous years. So look at the red, the bright red, which is on the very bottom. That's this current season. So as you can see, if you look over towards the middle of the graph at week 52, which is like kind of the end of December, beginning of January, you can see that again, the rate of hospitalizations is really not is not very high, compared to some other seasons. Look at 2017, 2018, the brown line, very, very high levels of hospitalizations a few years ago. But if you look at nationally, again, this year, the highest rates of hospitalizations, again, are among adults greater than age 65 and children under the age of 5. This is also very typical, really, of most flu seasons. Again, these are the most vulnerable populations. Even though we had, again, mostly flu B circulating, the individuals over the age of 65 likely were infected with A, with H1N1, or B as well. But again, they're just a more vulnerable population that result in these severe outcomes. And speaking of kind of risk factors for severe outcomes, I think it's interesting time to look at that. Very often a risk factor for hospitalizations resulting from flu infection are having underlying medical conditions. And if you look at this graph, again, if you just really look at the colors, 90% of hospitalized adults, with lab confirmed flu had underlying medical conditions. And the most common were cardiovascular disease, metabolic disorders, again like diabetes, and obesity as well. If you look at the green colors on the graph, that represents children and their underlying conditions, ones that get hospitalized for flu. I think it's really significant that over 50% of them have no underlying medical conditions at all. And again, I think that's significant because a healthy child without underlying medical conditions, again, can indeed, flu infections can be very severe, even in healthy kids, and they can turn very rapidly, and their clinical course can be severe, which again kind of underscores for us the importance of vaccination. The kids that do have underlying conditions, the most common one, 26%, have asthma. Okay, so that's nationally. Let's just take a quick look at what flu season looks like here in Georgia. You'll see a lot of similarities and a couple of differences as well. So far here in Georgia, again, our flu season is similar to the national picture, but we've had much, much higher levels of outpatient visits to the flu. And our indicators of severity, meaning hospitalizations and deaths, have also been higher than the national levels as well. You may ask why that is, and again, I may not know entirely. It may just be that we started earlier, that we in the South and that we in Georgia had a much earlier start, and it may sort of, in the national levels, may catch up, and we may balance out as well, or maybe there really are, again, just some differences. So for us, again, really early flu season, really early start. We started seeing some flu activity even in August, which is earlier than usual. And again, we've been seeing very widespread and high flu activity levels for the last 8 weeks. Here in Georgia, just like nationally, influenza B, Victoria, is the predominant virus that's circulating here, but we're also seeing a large increase over the last couple of weeks in influenza A, H1N1. When we look at our proportion of outpatient visits with influenza-like illness, our percentages are much, much higher than the national level. Remember, the national, average was about 6%, 5.8%. Ours has been really high. 2 weeks ago, we had 12% of all outpatient visits were 12%, really, really high. And just last week, it was almost 10%. So again, our, ILI indicators as far as outpatient goes seem to be higher than the national levels. And if we look at the other indicators in regards to the severity of flu infections, we have had 779 flu-associated hospitalizations in Metro Atlanta. So far, that's cumulative. And unfortunately, we have actually confirmed a total of 22 influenza-associated deaths here in Georgia. 11 of those were 65 years of age or older, and 4 of the 22 were among children. And if you look at this very same week, which is basically the first week of January last year, we had 5 total flu deaths, 5 total. So again, we've had many more flu deaths this year. Although I'll show you in slides to come, kind of a comparison. Last year, the flu deaths came much later in the year. So sometimes it really is just a matter of timing. Another thing that's been really high this year is the number of influenza outbreaks. And we've had 43 of them this year compared to 26 last year at the same time. The vast majority have been in schools or other congregate settings like long-term care facilities. So now let's just take a peek at some of the visualization of the bullets that I just showed you. So let's take a look at the influenza-like illness or ILI visits. These are outpatient visits. So again, we're looking at percentages of total visits seen by providers. Look at the red. So again, the last week of December, we had over 12% of provider visits were for influenza-like illness. And just last week, it went down a little bit to 10%. Does that mean that we peaked in the kind of end of December? I say let's hold off for that, making that designation. Very often we see a slight dip the week after the holidays. And the reason is just because, kind of because of holiday travel and holiday busyness, if you will, sometimes people are kind of less likely to seek care, to seek it in different places wherever they're traveling, so we're not getting it captured here. So let's wait a week or so, or a few weeks, to know whether or not we really are seeing some decreases. In every other way, it looks like, again, it's still going strong. Look at if you take a quick peek at last year, or I'm sorry, not last year, 2 years ago. That was a very, very severe flu season with that very large peak very late in the year. So every flu season is a little different. And again, we saw kind of last year in blue, we saw not as high of activity, but we saw it over a much longer period of time. We had flu activity all the way through May last year. So I think that these graphs are interesting to kind of show the differences from one season to the next, as far as when it begins, when it peaks, and when it ends. So if you look at, again, our ILI outpatient visits, these are just outpatient visits. I wanted to show you what age groups are affected. So early on in the season, if you look at the red triangles, again, the really little kids were predominant, kind of the predominant, age group that was being seen for ILI by healthcare providers. But now, over the last couple of weeks, the brown squares, again, indicate, sort of kids and teenagers, young adults. But if you look at the gray box, which is aged 25 to 49, that's coming up. That's the H1N1 crowd. That's the group that's kind of most likely to be impacted by H1N1 infection. So that's why we're seeing the sort of young to middle-aged adults now increasing. Again, as I mentioned earlier, we conduct surveillance for influenza-associated hospitalizations only in the 8-county metro Atlanta area. And we've confirmed 779 flu-related hospitalizations so far this year versus 674 last year. Not a huge difference. But if you just take a look at what we're seeing, again, we're seeing the very typical, just like the national picture, the people that end up being hospitalized are the little kids under age 5 and the older individuals over the age of 65. Let's take a look at our influenza-associated deaths this year. So again, I mentioned we had documented 22 so far. Our first one was, the very first one that we documented was in early November, actually. And as you can see, we have over the last few weeks documented several each week. But let's take a little deeper look at our flu-related deaths and compare them a little bit to some previous years. So the last column is is this year to date. So it's only through, again, the first week of January. So 22 total. And if you just kind of take a look at the other columns, let's compare that at this point in time. And again, only not halfway through the flu season, it may not have even peaked yet. Again, 22 compared to the 2009, 2010 H1N1 pandemic year, we had a total of 58 deaths. 2016, there were 23 total the whole year. And 2017, which was a very, very deadly flu year, there were a total of 154. So again, just as a matter of comparison and relativity. Remember I said that last year we had a total of 5 flu deaths at this time compared to 22 as of now. So last year we ended up with 44 total, but many of them occurred in March. They were just much, much later. So whether we indeed are getting the bulk of them earlier in the year and we're going to slow down, I can't say for certain, but that may be the case. So if we look at in just a little more detail, the tragedy of, again, pediatric flu deaths, we have documented 4 so far. 3 of our 4 actually did have underlying medical conditions, and only 1 of those 4 had been vaccinated against flu. I really want to highlight and underscore, again, how we cannot be complacent at all about flu in kids. I want to share with you a study that was recently done looking at the pediatric deaths that occurred in that very deadly 2017-2018 year. There were 180 pediatric flu deaths nationally that year, and that was nationally. And almost half of them, again, had no underlying medical conditions. Although the ones that did, again, had either asthma, most commonly, or obesity in 11% of them. And again, this is also very, very sobering. 2/3 of those children that died within a week of onset of their symptoms. Again, very, very rapid course of illness, very rapidly going downhill. And 35% of them actually died before they even made it to the hospital. And again, very consistent study after study after study. About 80% of pediatric flu deaths are not vaccinated. So again, this underscores for us, no matter the season, no matter the year, the importance, the critical importance of pediatric vaccination. Very prompt medical care to get them seen right away upon flu symptoms. They can go downhill so fast. And very early empiric antiviral treatment, without waiting for laboratory results. Get these kids on antivirals as soon as possible. So the take-home messages of all of this, and we've heard them all before, but I'll just bring everything together. CDC has some mathematical models that are sort of new this year that they call their flu forecasters. And the flu forecasters from CDC this year really are indicating that nationally, and likely here in Georgia as well, flu activity is likely to remain elevated through late January. So again, we still have several weeks or more ahead of us. It's really too soon to estimate the overall vaccine effectiveness for this season. but it's not too late to get a flu shot. If we still have flu virus circulating, it's not too late. It still remains the best method for preventing seasonal flu and is recommended for everyone over the age of 6 months. People who are at high risk of serious flu complications, hospitalization, death, should be treated empirically with antiviral drugs as soon as possible, within 48 hours of onset of their symptoms. And last but not least, no matter what, we cannot discount the very, very important adjunct measures, the prevention pillars in impacting the transmission of infectious diseases like flu. Hand washing, social distancing if you're sick, meaning don't go to work, don't go to school if you're sick with flu-like symptoms, and practicing, respiratory or cough etiquette. I would like to thank you all for your very kind attention. I'm happy to answer any questions that you might have.
Well, thank you, Dr. Green. An excellent presentation. And I'm happy that you're reinforcing the need for immunization, albeit the flu vaccine remains imperfect. And I only bring that up because people who have been immunized, although they are more likely to be protected, shouldn't neglect flu-like symptoms if they have them, and particularly with their children. And I wanted to ask you about the availability of antivirals and whether there's any shortage of Tamiflu.
No, we have not heard of any shortages in any of the antiviral categories, and again, it is a very, sort of, again, important, again, pillar of this, of prevention and treatment, especially in the young ones as well, so.
Thank you very much.
Thank you all, thanks.
Paige Jones and Dr. Sarah Blake.
Good afternoon, Commissioner, Chairman, and members of the board. Thank you so much for the opportunity today to share DPH. We are currently working on our Title V five-year needs assessment and wanted to share what we are doing around that effort. Every 5 years, the Georgia Department of Public Health is required to complete a needs assessment to assess the health needs of women, mothers, infants, children, and adolescents, to include children and youth with special health care needs. During this assessment, Title V collects information from the public health workforce, partners and stakeholders across the state to identify those needs and to address those healthcare needs through qualitative and quantitative data that is collected and used to inform our upcoming priorities, national performance measures, state performance measures, and work that will lead the maternal and child health section for the next 5 years. I wanted to begin by introducing my Title V team, Sherry Richardson and Linda Tranter here. We are working to lead this effort along with our maternal and child health epidemiology team and our performance improvement team, along with our maternal and child health workforce. The Title V Maternal and Child Health Program is the nation's oldest federal state partnership, enacted in 1935 as a part of the Social Security Act, and a key source of support for promoting and improving the health of our mothers, children, and youth, including those with special health care needs. The Title V block grant is funded by the Health Resources and Services Administration. The block grant is organized into 6 population domains: maternal women's health, perinatal health, children's health, adolescent health, children and youth with special health care needs, and cross-cutting. Currently, our cross-cutting is focused on oral health. "15 National Performance Measures, or NPMs, across 5 population health domains are established for the Title V Services Block Grant Program. Based on its identified priority needs, states select a minimum of 5 national performance measures for programmatic focus. For each of these selected NPMs, states develop at least one related evidence-based or evidence-informed strategy measure to assess and demonstrate the impact of its state's Title V strategies on improving those national performance measures. States also are given the opportunity to develop as many state performance measures as needed to address the priorities that were identified based on the findings of this comprehensive needs assessment. Title V legislation requires that each state and jurisdiction conduct a statewide comprehensive needs assessment every 5 years. Through this examination of the health status of women, children, and families in Georgia, that information is analyzed and the most current information is made available to the population domains. This provides us with an opportunity to reassess capacity, to identify new priorities, to align the existing infrastructure to meet those population needs. With this information and the results that we are gathering, we will select new priorities, create new partnerships, and develop an action plan that will move the needle on the selected NPMs and identify priority needs for the state. In order to comprehensively do this work, the Needs Assessment Work Group has been established to complete the needs assessment. The group consists of directors of management of the maternal and child health programs, our epidemiology team, and our program evaluation and performance improvement team. We have been working on this effort since January of last year. And the responsibility to include planning and completing these needs assessment activities. And eventually we will bring in all of our programs and incorporate all of those Title V staff in this decision making. So through this process, we are gathering both qualitative and quantitative data. We have developed surveys. To date, we have collected 574 total surveys. We developed a general population survey, a stakeholder survey, and a workforce survey. Our general public survey asked the general population, how would you rate services that we offer and what is your greatest need? Our stakeholder survey assessed our partnerships, our capacity building, their capacity building. We asked them, who do you serve? What is your ability to serve? And how can we partner with those stakeholders in the future? And our workforce survey looked at, from our perspective, what are our greatest needs that we see in our community and throughout our workforce. We conducted 10 focus group sessions. We began in September and ended that in December. We had 82 participants. Dr. Sarah Blake from Emory is on her way, if she is not here. Today was her first day of class, so she is getting her class started, and she will be here hopefully to discuss that a little bit more. Our next steps are, after we analyze the data, to select our top 20 to 30 parties that we see rise to the top from the needs that are established through these means of collecting data. Then we will hold 2 stakeholder meetings in February, one in Atlanta and one in Dublin, where we will ask our stakeholders to then rate those priorities that we have determined. They will choose around 10 to 12 priorities that then we will bring back, and MCH leadership will determine based on the data and all of the findings, what are those 5 to 8 priorities that we choose going forward for the next 5 years. We will then we will choose our national performance measures based on what those priorities are, and develop any state priority measures that are needed in order to do this work. So as I mentioned before, Dr. Sarah Blake and her team from Emory conducted our focus groups. I will touch base on this briefly, and when she arrives, she can give you more information on that. So we conducted our focus groups in Atlanta, Albany, Cordell, Dalton, Dublin, Rome, and Valdosta. We wanted to ensure that we worked with groups in both rural and urban areas of the state. As I said, we had 82 participants who represented diverse populations. We had mothers, fathers, teens, refugees, parents of children and youth with special health care needs. Rich conversations were held about the population's health care needs and also their uses of maternal and child health services. Further analysis is on the way, and those findings will be updated and will lend to our recommendations that we make. Let's see, she did provide some participant characteristics that I can briefly mention. A majority of the participants were female, African American, and between ages 18 and 29. They were mainly of reproductive age. 30% of the participants were pregnant and attended the 3 mother and refugee focus groups that were held. 50% of the participants had public insurance, Medicaid, and an equal number of participants had less than high school education, 36%, or had completed high school, 37.5%. And participants had an average of about 2 children, but in some focus groups that were conducted mainly around the refugee population, the average was much higher with 7 or more children. So our healthcare utilization, I'm going to look at these for just a moment, just gives our overall, the number of each participant category. And there's the insurance status, education level, children, and the group. And the overall picture with the healthcare utilization, where participants were asked what services they had used, would they or might they choose to use public health programs in the future? Have they ever heard about public health programs? The major takeaway was that a large majority of focus group participants are willing and would like to use public health services, even if they have not done so in the past. The refugee populations were less willing to use family planning services, but this may be due to cultural reasons. So some specific findings around healthcare utilization. Child well visit. A majority would or might use these services. Children with special health care needs, also a majority of those participants would like to use public health care services. Dental health programs, over half indicated they would use, but almost a quarter said they have used other public health services. A quarter have used family planning services, while 42% would use family planning. Almost 30% said they would not use. But these participants were refugees, where family planning may not be culturally appropriate or allowed. For STD testing, 30% have used STD testing, while 42% would use these services in the future. And pregnancy testing, equally participants have used the service or would use the service. A quarter would not, but again, this information may be skewed due to the refugee population. For visit screening, over 50% said they would be interested in screenings, and over 40% of the participants would use public health vaccination services. And I'm sorry, I wasn't familiar with these. This is on the next slide. So just in a very high-level overview, those are Dr. Blake's very minimal takeaways. She is doing further analysis and will provide those as we progress in the next month through our needs assessment process. Thought this was interesting. She posted some emerging themes from her focus groups. Throughout what we determined that we wanted to look at through this needs assessment process was access to care, quality, and health equity. And as you can see, some of her themes, emerging themes that came up a lot, and interestingly, with the 2 father populations that we did a focus group. They also mentioned that they were interested in more mental health care. And there are others that are related to, it's not laying out right. Hold on. What that is. On my notes. So violence and drugs is the green. I don't know if you have the words on your side. I don't think you do. And then healthy living programs for children, teen pregnancy, and transportation. You can see that. Dr. Blake is on her way and will be here, and she can potentially, if there's time, and if you're interested, add more to that. So as I mentioned, our next steps are to hold our stakeholder meetings in February, or we will provide them with the top things, the top priorities that were selected, and they will choose those 7 to 10 priorities that we then will come back and build our evidence strategies on how we are going to improve those efforts throughout the state and offer programming to our Georgia citizens. Thank you. Do you have any questions?
Questions or comments for Ms. Jones? I will. Thank you for the great presentation. I have a couple of questions. Presumably the focus groups are related to not whether people would ever use the service, but whether they would use the service that you offer. In other words, if somebody says they're unwilling to use family planning, they're unwilling to seek you out for family planning, it doesn't mean that they're not interested in family planning at all. Is that correct?
To an extent. So we did ask that question, are they interested in family planning? However, the other part of that was, are they interested in using public health family planning? And I believe the results were such because of the refugee population that was interviewed, due to their cultural beliefs, they do not talk about that. No one has ever given them that information. The other side of that is not only are we interested in, are they using our services, but what are their needs? Is that a need of the population? We offer that. What are other needs that we may or may not offer at this time? We want to assess that as well.
Are refugees eligible for receipt of MCH-funded services if they're not citizens?
Recently, in this last year, we did develop an evidence strategy with our refugee health department. We are interested in looking at and improving those newborn screening outcomes for that refugee population. I am not certain the level of health insurance that they are provided. I do know that there are community centers that specifically work with those refugee populations to help ensure they have the education and healthcare needs that their needs are.
Can the MCH grant provide them services? That's the question. If they're not citizens.
Right. I don't believe, if they don't have Medicaid, I'm not sure about that.
And they don't have Medicaid.
Yeah.
The reason I'm asking is that your program is occurring in the context of two other things going on in Georgia that are really a concern, public health. One is the excess maternal mortality, which results from a poor access to health services for women who are about to be pregnant, or have been pregnant. And there's a proposal that Medicaid funding be expanded for postpartum women up to as long as a year afterwards, partly in response to the maternal mortality epidemic in Georgia. Georgia is one of the worst states in the country in that area. The second thing is, as Dr. Drenzik points out, we've had big concerns about vaccine-preventable diseases. And I was particularly, it's hard to make a lot of comments, I'll do it anyway, but it's hard to make comments about 6 people who are refugees, but it seemed to me that the refugees wouldn't use any of the services for anything, including immunizations. And of course, not having any big population immunized is a threat to everyone in the state. So it would be good if if services at the state and federal level were made available for all refugees and immigrants, whether it's Medicaid or immunizations or whatever else,
Right.
to protect all people in the state, citizens or not.
That's why I was going to tell them. Yeah, they are, and actually, I know that no one is denied services based on that insurance source. And as I mentioned before, we wanted to increase that capacity to serve those refugees while we reached out to our refugee help program to try to see what can we start with, where can we start, and hopefully build on that as far as coordination of services, so that everyone has a coordinated means to help ensure that even if they aren't familiar with what's available throughout the state, that we can help link them to those resources so they can have those services that are available.
It seems like it'd be a major population to deal with because they don't use anything, not just family planning. It seems like they wouldn't use any of the services, either because they're not available or they don't know about them. And that could be a threat to everyone.
Right. And through this needs assessment, that's one of the beauties of that, is that we can see where are those gaps in services. How can we bridge those gaps? Who can we partner with? If we don't have the capacity, which we do in this case, but how can we partner with organizations and communities to do that? I know you mentioned infant mortality. We are currently developing an action plan to improve those birth outcomes.
I was talking about maternal mortality, but infant mortality is important too.
Mortality. I thought I heard you mention infant mortality too.
I will if you wish.
Okay, sure. I'd like to share that. But we're currently working also with our vital records and epidemiology to improve those fetal death certificates reporting, so we can have a more accurate picture of the state, those fetal deaths in the state. And we do work very closely with our Women's Health Director, Diane Durant. She is also a member of our needs assessment work group that I mentioned, so that we can make sure that we are facilitating all of that work and meeting those needs in order to improve that maternal mortality rate as well.
Thank you for the work you do in the refined report.
Thank you.
I did have one question.
Yes.
First of all, thank you for the work you do. In terms of collecting the data, it's hard for anyone to agree to fill out surveys. So I had a question about how do you encourage these participants to fill out surveys, and how long does it take, and how is it actually administered, and is there somebody there to help them, or just kind of give me some of the logistics of that, because I know your numbers are small, and looking at that, are there other ways to get more input is what I'm sort of wondering.
Yeah, sure. And we do have just under 600 surveys that we collected. Do you know the national, I've done surveys in the past, and also the national average for surveys are about 37%. But we did have, our means for getting that survey out to the community, to answer that question first, we used our stakeholders and our partners, because they are the hands-on, the boots-on-the-ground folks that serve our participants in the state. So we sent the survey to them, asked them to please send this to their programs, please have it available in their clinics, on their websites. We did have some partners that put the link on their website, that sent it out in newsletters. We had it on our DPH website, although that's determined by the traffic to the website. But we did reach out mainly through our partnerships and collaborating with them. They know how important this is, and we felt like that was the best means to get the word out that the survey was here. We did do a survey earlier in the year, and some of those county health departments also made it available that you could have access in the clinic. We offered this as a paper form as well as online, and we did find that we have a lot of paper. A lot of people choose to complete a survey in paper form rather than going to a link. I think that was a helpful way that we broadened that reach for providing that opportunity for folks. Our workforce survey, we had a maternal and child health conference where we provided that, and we also sent that out through emails and our departments here. And then again, always in asking our stakeholders to provide that population survey out, we asked them to also complete that and then share that with their partners. It may not be someone that we work with directly, but please share it with your partners and your community organizations that you work with in your communities. So that was our messaging for that.
Thank you very much, Paige.
Thank you.
Ms. Andrews?
Hope everyone's having a good afternoon. My name is Megan Andrews. I'm the Director of Government Relations for Public Health. The legislative session began yesterday with day 1, today was day 2, and they released out their schedule for the next couple weeks, and they're going to be jam-packed. Dr. Toomey is going to be presenting next week on Thursday at joint budget hearings before the House and the Senate budget committees about the new budget for amended fiscal year 20 and base budget for 21. So that's going on now. And I'll talk a little bit about some of the things that I'm doing in my office. One of my goals, I talked to several of you last year when I presented before the board, and one of my goals was to improve communications from our office to the rest of DPH to make sure everyone was well aware of what's going on at the Capitol. So part of that includes agency bill tracking. So there's a lot of bills that could have a potential impact on DPH, not just health-related bills, but things like minimum wage, or there's a broad range of topics. I think I'm tracking over 100 bills right now, just from last year that I've carried over. So we follow those bills through the process and make sure all of our health directors and state program level staff are made aware of what's going on. Part of that is as bills come in, they're shared with the impacted program to get their take on it. Whether there's going to be an impact to the department, is it going to cost us money, things of that nature. So I make sure that everyone's well aware of what's going on, and I think we made significant progress on that last year, and I'm hoping to continue that for this year. We will also, so we can all touch base midweek, and they can all be brought up to speed. Something new that we're doing this year that I'm very excited to talk about is Public Health Day at the Capitol. We are going to be hosting our district health directors at the Capitol on February 5th, and they're going to meet with legislators from their district to talk about some of the local issues going on around public health in those areas. They're going to be serving as doctors of the day, so if anyone's been at the Capitol, or some of you may have served, there's a physician every day that volunteers their time, and they serve in a small clinic on the second floor of the Capitol for anyone who has any health issues that can go see that doctor. So our health directors are going to be doctors of the day, which is really fun and exciting. We're going to have a resolution, and they're going to be able to go on the floor of both chambers. So I think it's a really great opportunity to show that public health is speaking with one voice, and we're taking a team approach. So I'm excited about our first ever Public Health Day at the Capitol. And I'm happy to take any questions if you guys have any about session. But it's definitely going to be a whirlwind this year. So, yes.
Thank you. Got busy several months ago, I'm sure, in advance. Is there any way that the board can receive the weekly updates of things that are upcoming? Is that? Would that be appropriate?
Yeah, that's fine with me. I can add you guys. I'll get with Fanny for email addresses.
Thank you.
Yeah, absolutely.
You're doing very important work, and I'm really impressed with how innovative it is to have all the health commissioners come in and be doctors as well as public health officials. I hope none of the legislators get ill.
I hope not too. And
But
one of the
if
questions
they,
that, I'm
If
sorry.
they do, they can be cured of their lack of knowledge of public health at the same time as their illness.
Well, hopefully no one shows up with the flu, but that was one of the questions one of the DHDs had was, what can I expect? I was like, well,
Maybe they could have flu shots available the same day, flu vaccine available the same day.
that would be nice. Dr. Toomey can.
Or Tamiflu as well. You'd have a supply of Tamiflu and a supply of flu vaccine, and Dr. Drensick could be there
Yes,
educating.
absolutely, absolutely. Yes.
Just a quick question. This is really a Medicaid issue, but it impacts public health. Consideration for expansion of Medicaid benefits for maternal coverage to a year. Do you know the status of where that is?
So I know that is, there was the House Maternal Mortality Study Committee that met through the summer and the fall, and that was one of the recommendations that came out of that study committee. I know Chairwoman Cooper has been beating that drum pretty persistently. I don't know where that is in the process. I think they're trying to work out what the fiscal impact will be, and that'll kind of lead where that's gonna go for this year. Any other questions? Yes.
I hope the press knows about this day when all the people from around the state are coming.
Well, there's a couple of them in this room, so maybe they'll be there. But we'll be taking photos with the governor, and I'm sure our press folks will probably be doing a press release or tweeting out or things of that nature.
Thank you very much.
Yeah, absolutely. I appreciate your time. Oh, yes, Dr. Toomey.
No, I was just going to say, we are very excited about this Public Health Day. It is the first time in history that there's been a Public Health Day at the Capitol that has brought in all the health directors. And it's just a wonderful opportunity for us to do a better job of letting the legislature know what we do and the breadth and depth of what we do, and then meet the leadership at the local level. And I think, we hope this will be the first of many public health days at the Capitol. And not to worry, the health directors who chose to be doctors of the day are closer to clinical medicine than I am, so not to worry. I could treat their chlamydia, but nothing else. So not to worry.
And keep it confidential.
All right, guys, thank you so much for your time. I appreciate it.
Thank you. Dr. Toomey, this is an excellent program. Do we have any other comments or new news or old news?
No, I think that you're welcome to join us at the Public Health Day at the Capitol, if you're around to be there. And we'll be educating about lead in childhood, which is something of great interest to us and concern, particularly with early brain development and during pregnancy as well as early childhood. And so that'll be one of the themes for our visit.
Probably the legislators are very aware of the problems in their own districts or their own counties, but this shows people that the diseases in the people don't abide by county lines or district lines, and that therefore there's a need for a state public health response to keep everyone protected. So I think it's a great sense of solidarity and a good idea.
Okay, thank you.
Any other comments? Do we have a move to adjourn?
So moved.
Second. All in favor?